Hello. On behalf of Natus Medical Incorporated Balance and Mobility, I welcome you to today's e-seminar on the topic of baseline concussion testing, featuring Dr. Wendy Novick from Alfred I. DuPont Hospital for Children. Dr. Novick is a senior physical therapist with the Nemours Children's Health System, Alfred I. DuPont Hospital for Children, Center for Sports Medicine. She earned her Bachelor of Science degree in kinesiology from Penn State University and her doctorate of physical therapy from Drexel University. Dr. Novick's areas of interest include pediatric patients with vestibular disorders and concussion rehabilitation. I'll now turn the presentation over to Dr. Novick.
Thank you, Mary. And as Mary said, my name is Wendy, and I'm a physical therapist with AI DuPont Hospital for Children. And a little bit of background about how our baseline concussion testing came about was we noticed when we were rehabilitating children post-concussion in physical therapy, and we were trying to make those difficult return to play, return to school, or even just gym class decisions. There were two really big distinct groups of children we were having difficulties with. Those children that had some sort of underlying balance or coordination issue, those clumsy kids that were not necessarily quote-unquote average to begin with, or those with some underlying vision issues like a convergence insufficiency. On the other side, we had those more adolescent elite level athletes who performed above average even after a concussion was sustained. And we really wanted to be confident in making sure that we were sending them basically back out on the field to be safe if another concussion was sustained. So overall, we wanted to be really confident in what our decisions were when returning somebody to sports. I currently have no disclosures. And here's our learning objectives for today. And really what I'd like everybody to take away from this is, the benefits to some sort of preseason baseline concussion test, what's available, especially in pediatrics, since most of this testing has been done at the collegiate and professional levels, and then kind of how to institute this kind of program at your facility. So just a little bit of background on concussion. This is one of many definitions out there about concussion. It was out of the consensus statement from Zurich in 2008 and 2012. There's actually another meeting in this year in October 16, which might tweak this definition a little bit. But it really is that complex process affecting the brain induced by trauma. The trauma can be either that direct blow to the head, face, or neck, somewhere within the body, or an impulsive force that gets transmitted to the head. There's typically a rapid onset of really short-lived impairments that will resolve spontaneously and follow kind of a sequential course. It really does reflect a functional disturbance rather than a structural injury, so that's why imaging is typically normal. And more often than not, it does not involve a loss of consciousness. So these are the most commonly reported signs and symptoms of a concussion within the first 3 days after sustaining it. And what you can start thinking about is what tests we have available as physical therapists, occupational therapists, that can help identify deficits in these areas, more focusing on the balance problems, the visual problems, and what we can really capture within our office. So a little bit of epidemiology. There's a really wide variance in reporting of the numbers on concussion. The numbers here are sport-related, so 1.7 to 3 million each year. And the reason there's such a wide variety is that we really don't know how many people get a concussion. Not everybody seeks medical treatment, so these only reflect people that sought treatment. And there's more and more people participating in recreational activities, so that number is probably going to steadily climb. So when specifically talking about pediatrics, before the age of 10, most concussions are related to falls at home, at school, during gym class, on the playground. But after the age of 10, really most concussions are sustained during a sport or recreation type activity. Again, half of concussions do go unreported, so that's why we do see this wide variance in numbers. And girls tend to be at a slightly higher risk than boys, whether that is due to weaker neck musculature, as been reported in the literature, or that girls are a little bit more likely to report that they're having symptoms than the boys. And the sports that really do have the highest risks, for boys, we're talking about football and then soccer, girls, soccer and basketball, but other collision-type sports, rugby, ice hockey, lacrosse, also have a very high risk. So when talking about baseline testing, it really is widely utilized at the collegiate and then professional level, and it has been for greater than 10 years. I think it really expanded with the development of computer-based neurocognitive assessment, and IMPACT has been the most widely utilized neurocognitive tool since 2006. Typically, it is administered preseason, ideally before the first practice, and then post-injury to kind of assess where the athlete is functioning. And overall, we're aiming for the baseline test to help us really make those hard return-to-play decisions. So a great example of this, in 2015, so last year, there was a joint venture between the NCAA and the Department of Defense to really try to study and prevent concussions. So their goal was really to understand, number one, what a concussion is, how do people recover for it, and what are the differences in how people recover from it, and then ultimately, how do we prevent a concussion? How do we keep our student athletes, our service members, how do we keep them safe and try to lower these numbers that we're seeing? So currently 32 institutions are participating, including national universities as well as all of the armed forces academies. The assessments that they do consist of a baseline, and then if a concussion is sustained, the post-concussive assessment. And there's two distinct groups within this, the clinical core and then the advanced core. And we'll go through a little bit about the differences in those two protocols. So the clinical core does a basic demographic and history, including an injury history, impact test for their neurocognitive assessment. They'll do an assessment of neurological status with cranial nerves. They do test postural stability with the BEST and, if able, the SOT. There's a test of clinical reaction time, the ocular motor, ocular vestibular assessments, which include the King-Devitt test and the VOMS, several quality of life measures, and then a symptom score, the SCAT, which is the sideline tool that is most widely utilized if a concussion is sustained. Now, the advanced core includes all of the same assessments as the clinical core, but with four broader, or more specific, I should say, categories. So if appropriate, they're doing head impact sensors so that they can try to capture what type of force the hit took to have a concussion. They're doing baseline 3T MRIs. They're genotyping, and then they're doing a blood biomarker study. So the goal of those is to really try to break down what are the differences in people, why some recover quickly, some don't, why some will get a hit at the same force and not sustain a concussion while somebody else does. They're also looking at the blood biomarker studies to help try to see if any sort of serum levels change post-concussion that we can capture with a blood test to more confidently make a decision that yes, a concussion has occurred, and then retest to say, and yes, we are now recovered and back to our baseline. So as of June of this year, 2016, the clinical core has screened over 18,000 student athletes and service cadets, and then they've captured a little over 1,000 concussions. So that's about a 15-16% rate of concussion within that population. And the advanced core, which is a smaller population, they have a total enrollment of 540, and they've captured about 45 injuries. So they're on their way to really collecting all of this data so that, down at the next level, we can help use these types, this type of data, this type of information in our clinical decision-making about concussion. So as we come down to more youth sports, concussion laws have now been instated in all 50 states, and with these return-to-play laws. So there are 3 action steps within these return-to-play laws, which include education, mostly for the coaches and the parents, with the athletes as well, to kind of recognize what a concussion is and speak up if a concussion is sustained. Everybody, if a concussion is suspected, they are removed from play. There is no more sending somebody back in. If somebody was suspected to have a concussion, they will be out for the rest of that day. And then the last is to obtain permission or clearance for return to play from a healthcare professional that knows how to treat concussions. So of note with these concussion laws, right now, they're only governing school-based sports. So they are not governing those youth sports, those travel teams that a lot of our kids are playing on. Several states, I believe 3 or 4 states, including Illinois, are amending their laws to now cover youth sports as well, but that has not occurred yet. So that is a group that really is a little bit more vulnerable to some of the effects of concussion. So when specifically talking about baselines in the younger population, children and adolescents, we need to consider that now over 40 million youth ages 6 to 17 are playing organized sports every year. That's including school-based and youth sports or recreational sports. And within this population, the concussion tests have been developed for use at the collegiate and professional levels, really haven't been used much in the pediatric population. So there are no norms, and it actually, a lot of them aren't developmentally appropriate for these children. So when you consider that we have an immature body system in this age group, trying to compare children to adult normative data really can be problematic. So if you think about it, our somatosensory system really isn't maturing till, 10 to 12 years of age, and the vestibular system doesn't mature to 15 to 16. Even at the college age, that's when the full brain myelination is really complete. So trying to make these correlations between children and adult norms really aren't going to get us in a good position. So when we considered making our program for baselines for children, we really want a child to be able to be compared to themselves instead of the normative data. And this is where we're really capturing those kids that I was talking about in the beginning. Number one, the clumsy kids, the ones that aren't going to perform normal or average on testing before an injury is even sustained. Now they can be compared to themselves so we can better make a decision about if they're back to quote-unquote their normal. And then again, for the higher level athlete, we want to make sure that they're scoring within the same range when they go back as well. At this point, we're recommending a repeat testing every 2 years, which really does allow for us to capture changes in performance and growth and development, and that happens to be the recommendation of IMPACT as well. And we want to do a comprehensive screen. So we're not just trying to get an idea of their cognitive performance, but we want to get an idea of their physical performance as well. So within our protocol, our comprehensive testing protocol, our categories are neurocognitive testing, balance testing, and then visual and ocular motor testing. And we select our tests based on the age group that we're dealing with. And how we've broken down the age groups is the 8 to 11-year-olds and then the 12 to 18-year-olds. And as we go through, we'll talk about what tests we select for each and kind of why. So for neurocognitive testing, we are actually only doing this within the 12 to 18-year-old group right now. And that is due to the demands for attention and the ability to follow directions for these computer-based tests. So we are utilizing IMPACT as the current license we have within our facility. And what IMPACT really measures is reaction time, our visual and verbal working memory, processing speed, attention span, and then concentration. And they have already pretty much established really excellent reliability and validity with that good sensitivity to really identify deficits post-injury. Other examples of computer-based tests include the Axon Sport, which is the old COG Sport, Headminders, or ANAM, which is used by the military. But currently we use IMPACT because we have the license for it within our facility. And that is what our physicians are using post-concussion. Of note, IMPACT, just a couple weeks ago, about 4 weeks ago, we got the email that IMPACT just got FDA approval for a new version of their test for ages 5 to 11. So stay tuned. We might consider adding that into our testing for the younger age group as well. So our balance testing has two portions. The first portion is our dynamic posturography, which we are utilizing in both age groups, so for all the children coming in for baseline testing. And specifically, we're doing the sensory organization test. So what the SOT does is it objectively assesses a person's ability to utilize their sensory systems to maintain postural control, the somatosensory, the visual, and vestibular systems. The SOT already has established norms down to the age of 3, which is great for us, and has been shown to detect changes in postural control post-concussion. And I think we're still talking between 48 to 72 hours post-concussion, so it's able to detect those small changes. And what we want to use it at from a baseline standpoint for it is to really help identify those underlying deficits within postural control, mostly related to the vestibular system. We are a very big health system, and so we can see children of all ability levels. We see a lot of kids with hearing loss. We see children that have cochlear implants. We see children with CP. So we want to be able to help really capture what their typical performance is. So just as a refresher, the SOT, these are the 6 conditions that we're utilizing, and it utilizes changes in vision and then sway referencing of the surround and the surface to help isolate each sensory system. And what we're really looking for is performance on, conditions 4, 5, 6, specifically 5 and 6, to really see at baseline how the child is performing. So if dynamic posturography isn't available, we're going to try to utilize static posturography as well. So we can do the Modified Clinical Test of Sensory Integration on Balance, the MCTSIB, which measures postural sway under 4 conditions, which are double leg stance, eyes open, and eyes closed on firm and foam surfaces. The SET test, the Stability Evaluation Test, takes it kind of a step further, and it assesses the postural sway under 6 conditions, which are the same as the BEST, which we'll describe later, but it's double leg stance, single leg stance, tandem stance on firm and foam surfaces, all with eyes closed. So this really was specifically designed as a concussion test. If no kinds of force plate testing is available, something like the old foam and dome, the CTSIB, could be utilized as well. So the other arm of our balance testing is more of our functional balance testing. So for the ages 8 to 11, we are utilizing the Bruniss-Oseretsky Test of Motor Proficiency 2, their balance subtest. It has been established as a great norm reference test with good psychometric properties in children, down to the age of 4. And really we're looking at the motor skills integral for maintaining posture with static and dynamic tasks. So the tasks include tandem stance, single leg stance, tandem walking, with eyes open, eyes closed, not for the walk, and then utilizes a balance beam to narrow the base of support. For the children the adolescents ages 12 to 18, we're utilizing the BEST, the Balance Error Scoring System, which was specifically designed as a concussion test on the sideline to help detect if there's a balance change after a suspected concussion. So again, like the SET test, there's 3 stance conditions, double leg, single leg, and tandem stance on firm and foam surfaces. Each trial is 20 seconds, all with eyes closed. And what we do during this test is we tabulate errors from the standard position that they are placed in. So the errors can include hands off the hips, eyes opening, a step or a fall, the hips going into more than 30 degrees of hip abduction, the lifting of the forefoot or heel, or remaining out of the original test position for about greater than 5 seconds. Of note here, the original norms that were published were based off of collegiate age athletes. So for the 8 to 11-year-olds, the BEST isn't the best test because it's a little too complex for their developmental age. So the demands that it really places on the vestibular and somatosensory system are a little bit too great for the developmental age on that foam surface. We have utilized a modified version of this on the firm surface only, but it really hasn't been validated. And for the 12 to 18-year-olds, the BOT is just not utilized because we do see a very big ceiling effect with this. It's a little bit too easy for the older kids at their baseline, at their normal performance level. And we might not be able to capture any kind of change in their performance post-concussion. If those tests don't want to be utilized, another good test would be the Dynamic Gait Index, which is nice because it definitely engages the vestibular system, being as a lot of the balance tests are done walking. There are no pediatric norms, but if we're doing a baseline, a child can be compared to themselves, so that would work. The Pediatric Balance Gear, the PBS, which is a modified version of the Berg, is a 14-item scale really related to function of children. There are norms, however, there likely will be a ceiling effect as well within this in typically developing children. This would be a great idea if you are seeing children with various ability levels. So it has been validated in children with CP as well as children with Down syndrome. The times up and go and the functional reach are popular tests that they do in the pediatric population, but again, probably not sensitive enough to detect changes post-concussion. So moving on to our visual and vestibular ocular portion. In both age groups, we're doing the King-Devick test. So what the King-Devick test is basically an objective way of measuring visual tracking and saccadic eye movements. The subject is asked to read numbers from left to right across each line, and it's over 3 different trials which get much harder on each page. And what is recorded is the time it takes to read all the numbers and the number of errors that the subject made while trying to read them across the line. And studies have shown that it can detect changes in performance from baseline immediately post-concussion on the sideline. So a lot of groups are now using it on the sideline if a concussion is suspected. It has been norm referenced in typically developing children from ages 6 to 14 and has really gained popularity in probably the last 1 to 2 years. The VOMS, the vestibular ocular motor screen, is being done in the 8 to 11-year-old age group. And we're doing a modified version of it. So the original VOMS was out of the UPMC program in Pittsburgh. And what it does is it assesses the vestibular ocular system. So it does smooth pursuits, saccades, VOR, near point convergence, and visual motion sensitivity. And in the original version, what they assess is symptoms reproduced in each of these. But since we're doing this as a baseline assessment, we'd hope, number one, that there were no symptoms reproduced. And so number two, what we end up doing is assessing the quality of the movement that we're seeing. Currently, there's no normative data for their version or our version. But it allows us to capture those, coordination deficits that we can see in the younger age children since the saccadic eye system is not matured at this age. So here is a little bit of a summary of our testing protocol. So the ages 8 to 11, again, what we're doing is the modified VOMS, the NeuroCom SOT, the BOT2 balance subtest, and then the King-Devick. And this can, as long as people are cooperating, take us about 25 minutes to complete. In the 12 to 18-year-old group, we're doing the impact test first. We're doing the NeuroCom SOT, the BESS, and then the King-Devick. And we can get this done in about 50 minutes, 50 to 55 minutes, depending on how long impact is taken. And so how we have this work is each participant comes in for the older group and takes the impact test first in an individual room to kind of help with the validity of testing. They've kind of seen that the group testing in computer labs doesn't really work well, and that a lot of the results are invalid. So we set each child up in an individual room. The remainder of the testing is done in a station format to maximize time and decrease the staffing needed for each screen, so that helps us lower the cost for the families. Other areas to consider testing that we've not added in yet, but that we've been thinking about are a coordination test, I would say specifically in the younger age group, so perhaps we would use the BOT2 coordination subtest. Some kind of measure of clinical reaction time, which we are not doing yet, but we are looking for something that we can measure reaction time. In the younger population, impact will give us a reaction time measure in the older group. And then the other thing that we can consider doing in the younger group is a symptom checklist. Currently, again, part of the impact test is doing a symptom checklist pre and post testing. We are not doing that in our younger group just yet. And how these tests are being utilized, all results are sent to the family to keep on file if a concussion is sustained. And then if one is sustained, they can bring these results to their physician, to their athletic trainer, to hopefully administer some of the tests again in the office to help determine what level of impairment the child is showing. So more likely than not, the impact test, the BESS or modified BESS if they don't have the foam, the King-Devick test or kind of that ocular motor screen if the practitioner is trained in it. And if the physician wants, they can send the child back to PT for the full battery of retesting, so more like the SOT if they are really concerned. So I just wanted to kind of show how we utilize these results with a bit of a case study. So we had an 18-year-old rugby player who received his baseline balance testing on February 22nd, and he had the older version, so the impact, the SOT, the BESS, and the King-Devick. Unfortunately, he did sustain a concussion in April, and he presented for a physician evaluation at our facility on April 29th. Testing was readministered at that time, and then when he didn't recover fully, he was sent for a PT evaluation about 1 month later, 3 weeks later. So at the PT eval, so this is about 3 weeks post-concussion, he was still only feeling about 65% back to his normal self. His vestibular ocular screen showed abnormal smooth pursuits, saccades, and visual motion sensitivity with a mild convergence insufficiency. And what you see on the right is his SCAT. So he scored he had 12 symptoms with a severity score of 12. So not a very high severity score, but he was still reporting that he only felt about 65% back to his normal self. So here are his results from baseline and post-injury on the SOT. We utilized the equilibrium score, which is an average of the 3 trials. And so you'll see he actually did better post-injury than he did at baseline. Some of this might have been familiarity with the test. But so this wouldn't be a great measure for us to say if he was back to his baseline, right? So this is, we're actually seeing improved results. So on the best, you can kind of see that at baseline, he did not have a very good score. So about 12 is average. Our standard deviation goes about 7 in each way. So a 19 would still be average, but he scored a 26 at baseline. But if you'll note, post-injury at his evaluation, he scored a 33. So it got even worse from there. And what you'll see is the foam surface stayed pretty consistently bad, but he really had more difficulty on that firm surface, which was concerning for us. On the King-Devick, we'll note that his time increased by 5 seconds. So he definitely was reading slower and was less efficient with his saccadic eye movements. And here are his impact results. Now you'll see the baseline. We didn't do the post-injury test until he was feeling better, so we didn't do that till July. So this is probably after we already did our PT, and he was still showing some deficits in reaction time. That's the big one that we're seeing here. So we did pick him up for formal PT sessions for 6 weeks. We held him out of contact sport during that time, but his big goal was to get back to golf, which we were able to do once his dizziness resolved and his vestibular ocular system returned back to his normal. He was able to graduate from high school within that time. He ended up not taking his finals, which his school was fine with. And then we did hold him out for driving for quite a good amount of time due to the deficits in his reaction time. So that's kind of how we utilized his baseline results to help, make decisions not only about recommendation for PT, identify what deficits we saw from his normal, and really try to return him as best as we could to all of his desired activities. So just to wrap up, baseline concussion testing is definitely gaining popularity, especially at the higher level, but really considering that we have so many children playing sports now and contact sports at a young age, that it's beneficial at all levels of sport. And because we see such a wide range of quote-unquote normal in the pediatric population and a wide range of ability levels, we should really try to have our families consider doing something like a baseline test just in case, that concussion is sustained, and we can return them to their activities in appropriate time. It should be comprehensive in nature, so not just include impact testing. It really should include both a screen of the balance system and the visual vestibular ocular system. If a concussion is sustained, then the athlete can be compared to themselves rather than relying on normative data, which is really what we want to do to help ensure that we get them back to their normal. Quote-unquote normal is not the same for everybody, and so we want to return a child to their normal status. And this can really help us, the baseline testing can help us make more confident return to play and return to learn decisions so that we can hold someone out longer or return them sooner depending on what their baseline levels really were. So thank you very much. I have a couple references for everybody about the testing today, as well as some background on concussion. And feel free to contact me with the email within this if you have any questions in the future. And I'll send it back over to Mary.
Thank you, Dr. Novick, for sharing your experience and expertise with concussion in the pediatric and young adult population. I would like to remind all of our participants to log into our website, balanceandmobility.com or nervecenter.natus.com to view this and other recorded e-seminars and also to access our calendar of upcoming live events.